Welcome back to Africa Science Focus, the weekly science and development show from SciDevNet. I'm Ogechi Kianyao. In today's episode of our Science Explained series, we're exploring how countries like Mozambique and Malawi are fighting polio. Polio is a highly infectious virus that mainly affects children under 5. It spreads from person to person, mainly through the fecal-oral route, which means the virus spreads when people ingest anything contaminated with feces. It then multiplies in the intestine and can invade the nervous system, causing paralysis. In 2020, the World Health Organization declared Africa free of the wild polio virus. This milestone was achieved through widespread vaccination campaigns, improved sanitation, and better public health infrastructure. However, in 2022, the wild polio virus reemerged in Mozambique and Malawi, setting back this significant progress. To contribute to the global polio eradication efforts, organizations like Village Reach and the Global Polio Eradication Initiative stepped in to help stop the outbreaks. They focused on improving the transportation of lab samples, as according to the World Health Organization, delayed and improper transportation can affect test results. And efficient testing is crucial because it allows for the rapid detection of the virus, enabling health authorities to respond quickly and contain outbreaks before they spread further. In a global health effort, countries and health organizations like the Global Polio Eradication Initiative and Village Reach joined forces to launch massive vaccination campaigns. These campaigns helped to stop the spread of the virus and reached over 50 million children across 5 countries, including Malawi, Mozambique, Tanzania, Zambia, and Zimbabwe. On May 14th, an independent polio outbreak response assessment team recommended the closure of the wild poliovirus type 1 outbreak in Malawi and Mozambique. Our reporter, Justice Baidoo, spoke to Sedeya Gamer, Senior Program Manager for the Polio Outbreak Response at the United Nations Children's Fund, to find out the reasons behind the polio resurgence in 2022.
I think overall, what we've seen over the past years is that millions of children are still missing out on vaccines, such as polio. And that's not just the case in Malawi and Mozambique, but it's a more global phenomenon. So I think according to the 2003 State of the World Children's Report, the fear was that up to 67 million were missing on vaccination between 2019 and 2021. Obviously, with the impact of COVID, decline in immunization coverage, and so forth. So in the cases of Mozambique and Malawi, and several actually other countries across the African continent, there are several challenges that lead as well to this increase in cases and to resurgences. Displacement, conflict, climate disasters, in some extent, political insecurity. Obviously, we also have sometimes distrust in government or in science, and overall fatigue as well around vaccination. So I would say these are some of the main reasons why we've seen some resurgences and why we're really scaling up what we call polio outbreak response, especially on the African continent, with the view to end transmission next year.
And how bad has these resurgence been, especially for some of the victims in these areas?
It's pretty tragic, right? We always say even one case or one child affected is a catastrophe and something that we must prevent. We over the past 5 years, more than 3,500 children have been paralyzed by polio, and the majority of them were in Sub-Saharan Africa. So that shows a bit the scale of the issue. And we estimate that 1 in 200 infected person will suffer from irreversible paralysis. So, we really believe in UNICEF and across the GPI and across the polio partnership as well, that responding to polio outbreaks, preventing resurgences is a child rights issue. We really need to make sure that all children have the same opportunities to survive and thrive. Because obviously, as we see for other diseases, it's usually the most vulnerable communities that are affected the most.
Next, we hear from Maziko Matemba, Malawian public health rights advocate, who tells us more about the polio outbreak in Malawi.
Polio is caused by 3 types of poliovirus. and more especially is spread due to contact with infected feces. So issues of poor hand washing and all those. So, and also issues of maybe happening from eating or drinking contaminated food or water. You can see now that issues of hygiene, water and sanitation, I think have been key as one of the key contributor to the current polio, or which Malawi has had cases.
So also tell me generally about the rate around polio in Malawi specifically. How is it being generally?
Yeah, for Malawi, I think it took us almost 30 years without registering polio cases. But in the last 2 years, we have seen that increase of polio cases in Malawi after 30 years. And one such a case came from the central region of Malawi. And it is suspected that it was an imported case from India. So after that imported case, we have seen that we have seen upsurge of polio cases in more especially in major towns, in Blantyre but also in Lilongwe. So most of the cases are concentrated in most of the major cities.
So what do you think are the sort of gaps within the public health systems in Malawi, especially and also around the countries around Malawi generally, that allowed for these new cases to occur?
Well, I think we have seen lapses and gaps because, as I said, it took us almost 30 years without registering any polio case because of our robust immunization program. As you know, Malawi, we have the WHO guided expanded program for immunization, which specifically deals with vaccination, more especially for the under 5. So we have been doing well on the traditional vaccine, that including polio, for some time. But one of the things which we just observed coming these years because of issues of climate change, but also issues of disruption of services because of the environment is changing. Because of the climate change, Malawi was faced with the cyclone Freddy, and also we have had floods. So there have been some, we believe these cases are coming out of the fact that our environment keep on changing, but also because of the robust reporting system. Because currently we have reporting systems, as you know, in this new era. 3 years ago, we didn't have robust media platforms, like social media platforms. So people can easily be able to report these cases. So maybe we might say maybe the last 30 years, there was no case, but because we didn't have that robust media reporting, now we have community radios, but also we have these national radio, traditional radio stations, and also newspapers. So the coming of media, but also COVID-19, because COVID-19 also uncovered some of the gaps in terms of reporting for immunization and cases. So it is the collection of many factors why now we are seeing the absence of polio, but we cannot lose sight because of our porous borders, but also our ability to test most of the vaccine preventable diseases. Because what we have just observed, that as a country, I think we need to do much in terms of making sure that we have robust systems. For example, the case which came from India when it was tracked is that someone had contacted polio from India and it was transported to Malawi because our systems couldn't track it because maybe our border post entry, they don't do much in terms of monitoring, but also maybe screening people who are coming in country. So we have had that challenge over time. That's why maybe seeing these cases of the disease.
Eradicating diseases such as polio requires proactive interventions, including ensuring that there are structures to detect cases as early as possible. Luciana Maxim, Director for Health Supply Chain and Lab System Strengthening at Village Reach, shared how the organization transported lab samples to aid fast detection.
We are aiming to improve the speed and quality of polio sample transportation from communities and health facilities in about 15 countries in Africa to faraway national and international labs.
So tell me about the lab sample transport for polio eradication project. Tell me, what is it?
So maybe I can start with a story. In early 2022, I think it was February or March, a child in Lilongwe, Malawi, was diagnosed with a wild poliovirus. And it was the first such case in Malawi in 30 years, and in Africa in about 5 or 6 years. That's because the continent had eliminated wild polio a few years prior. So in the case of this child, diagnosis took over 2 months because the closest laboratory was in Johannesburg, South Africa. And then shortly after, 8 more cases of wild polio were detected right across the border in Mozambique, triggering mass vaccination campaigns of over 33 million children in 5 countries. So what happened was that this was right after the COVID pandemic. As you know, routine immunizations for children had been disrupted for about 2 years during COVID. And because this case had been missed for so long, a huge vaccination campaign was needed in a very large area, so quite a few neighboring countries, in order to squash the outbreak. So the problem, that was at the time we were starting to do assessments in these 15 countries on behalf of the Global Polio Eradication Initiative, with funding from the Bill and Melinda Gates Foundation. And the main problem we were trying to help solve was how to catch and suppress any polio outbreaks quickly. And what we found was that in the 15 countries that were considered at high risk of polio reemergence in Africa, where we conducted these assessments in the first half of 2022, only about 6 countries were meeting the 3-day target set by the World Health Organization. So what we found through the assessments were that many of the countries were very far from this target of 3 days. For example, Mozambique had the worst baseline that we found in 2022. It took about 30 days instead of 3 to get samples from any corner of the country to the lab, which is in Johannesburg, South Africa. So really, a lot of the countries that didn't have labs in country for polio were really struggling with meeting these tight targets. And then that delayed further the diagnosis back to the parents of the child and to the clinicians, because it also takes a couple of weeks to process the samples at the lab. And then one other thing we found is that some countries, not many, but some, were struggling with the quality of samples. So you go through all this trouble to get a sample from a very remote community to a national or international lab, but maybe the cold chain wasn't respected. Usually the samples need to travel at 2 to 8 degrees Celsius. And you get to the lab and the lab is not able to perform the analysis because the sample has been compromised, and you may get a false result. And then some countries had trouble with data. We couldn't even find the data. How long does it take? Where are the bottlenecks? Where are the samples getting stuck? At which point are the ice packs that the samples travel with melting? What can we do to move these samples faster, and what can we do to maintain the required temperature range for many, many days during transport and in very hot environments?
Luciana also told us the steps Village Reach adopted to remove the barriers preventing efficient transportation of samples.
We worked in mid to late 2022 with national and local governments, with the World Health Organization, the Africa Regional Bureau, AFRO, and then all the WHO country offices, and with many other in-country stakeholders to customize solutions that would radically improve the speed and quality of sample transport in a short period of time. We were given about a year to do this. So we used a combination of approaches. No one approach was going to dramatically reduce the duration of transport. So we added on-demand, immediate sample pickups from health facilities anywhere in the countries. And in addition to the less frequent or scheduled pickups, which seemed to be the norm, and that's because transportation over long distances can be very expensive. So there tends to be more routine pickups, and then the samples are batched. But if you're trying to prevent an outbreak, you need to move the samples for every patient immediately. So we added those on-demand, immediate sample pickups. We also found that most of the samples were being moved by health staff, by community health workers up to a certain point, by health facility workers. They would leave their posts for days to go to the national capital with the sample of one child. So in the meantime, you have patients back at the facility who have other problems. They need immediate attention, but the health workers have to travel themselves with the samples. So we built a large network in many countries of private transporters, local transporters, wherever this made sense, places like DRC, Guinea, Niger, Chad. And it's a combination of transporters. It could be, the postal service. It could be local motorcycle taxis, individuals or associations, passenger minivans. Of course, all of this requires training for, how the samples should be packaged and stored and transported, biosafety training, because these are potentially infectious diseases. So we worked on all of this in addition to, in the countries where it made sense to continue using health workers, we reorganized the incentives to make them more equitable and more performance-based. So we used both of those approaches, and we saw good results with both types of transport.
Luciana also highlighted some challenges the program has faced.
So many challenges. So what happens is, polio is worldwide is very close to eradication, right? There are only two remaining endemic countries where there's wild polio virus. That's Afghanistan and Pakistan. In Africa, they're mostly nowadays vaccine-derived cases. So in very rare cases, you have to vaccinate everybody, but in very rare cases, the weakened virus in that vaccine may mutate and it could end up causing paralysis, but it's very, very rare. And now there is a new vaccine out there that seems to be solving most of that problem. So what happens is that the virus nowadays tends to hide, whether it's vaccine-derived or wild polio, tends to hide in maybe in communities that are under-vaccinated, so where you have a lot of children that haven't received all their routine immunizations, including for polio, what we call under-immunized or zero-dose children. And then when you end up with a cluster of children that are not vaccinated, then you may end up with an outbreak in those areas. So as you might imagine, a lot of the children that are under-immunized tend to be in very remote, hard-to-reach areas. Like in Chad, we're talking deserts. In Ethiopia, we're working in some of the areas where there's instability and famine. In northern Nigeria, there's conflict. Speaking of the health workers, only some very trusted health workers can get in and out of certain places with samples. So you can't even send a private transporter in some places, even if you wanted to. Or northern Mozambique, you also have conflicts, and you can't get the samples out fast enough because there's a schedule, there are convoys of transport that can get in and out with medicines and vaccines and to pick up lab samples. So I would say one of the biggest challenges is finding the virus in some of these very remote places, finding the children that are showing symptoms. And then if, nowadays 99.99% of these acute flaccid paralysis, AFP samples that go to a lab turn out not to be polio, because polio is on its last legs. But it could be something else, right? It could be something else. And then in that case, while polio is not curable, you could help treat that child. If it's not polio, if you know fast enough, then you can help treat that child for whatever is causing that muscle weakness or paralysis. But the challenge of getting transport to these places, the challenge of working with communities and large networks of local transporters to say, these are urgent, these are outbreak-prone diseases. So it's a little bit different from HIV, TB, where maybe it's not as urgent to get them to the lab, or maybe the labs are everywhere in the country at the district or provincial level with polio, Ebola, some of these more rare, highly, epidemic-prone diseases. You have to get them to a high-level lab in the national capital or abroad. And so first, you're having to find the children, figure out if there is an outbreak, make sure you get the samples to the lab very fast. But we're talking thousands of kilometers in some cases. Like if you're thinking DRC, Ethiopia, Nigeria, Mozambique, these are big countries. You also may have populations on the move, either seasonal, workers or people running away from conflict. So how do you catch the children? And how do you know if they've been vaccinated or not? It's a huge challenge. And then getting the samples so fast. 72 hours, you can imagine. In DRC, you may have people walking on foot, right, up to a facility with a stool sample. Then, they may have to get on a motorcycle to take them up to a certain place. Then you might have a car coming to pick it up. Eventually, those samples will have to fly from a provincial airport to Kinshasa to the lab. And then you get stuck in traffic with that sample in Kinshasa in a car to try to deliver it to the lab. So huge challenge there. And then, as you might imagine, huge challenge in terms of costs, right? There's nothing inherently cost-effective about moving an outbreak-prone disease sample to a lab. You cannot batch those samples because you're delaying them. So you can't wait for a bunch of children to get tested. And those symptoms are very rare. They might pop up in different corners of the country. You just don't know where those cases will pop up in a big country. And so you can't wait to batch them and send them. You might be able to do that with HIV samples, but you're not able to do that with an outbreak-prone disease, because the longer you're waiting, the higher the chances of that outbreak spreading. And it's very unfortunate. Actually, we've had in the 15 countries that we've been working on for the last year and a half to 2 years. So out of 15 countries, 12 or 13 of them have experienced polio outbreaks during this time. In most cases, the countries that are able to move the lab samples fast, they can squash the outbreak pretty fast. So you end up maybe with one case or a handful of polio cases. And then the response is to send an army of vaccinators to these areas and try to find every child and vaccinate every child. So sometimes you have to do door-to-door vaccination campaigns. And then that contains that outbreak from spreading. But other countries, for example, DRC right now has been in a tough situation since late 2022. They've had hundreds of paralysis cases in children. So I think I read somewhere that last year they had half of the cases on the continent in DRC. So in DRC, it's just the challenge is so vast because of distances and many remote communities, very low access to maybe cell phone towers to call out. So it's a huge effort, especially at the community level, to get the communities involved in notifying these cases whenever it looks like it could be an outbreak-prone disease. There's also constant outbreaks, competing outbreaks, yellow fever, measles, cholera has been really bad lately all over the place. Uganda has had an Ebola outbreak. So again, when some of these things happen, it might not be polio, but it distracts some of the same health workers and some of the same lab technicians and disease surveillance officers because they have to focus on squashing that outbreaks. So those, I think, are some of the challenges. And maybe just to go back to costs a little bit, again, you can't batch the samples. So if you have to move every simple sample and you have to move them fast, you usually have to pay a premium for speed, right? That transporter has to, drop everything to go pick up the sample, and it takes them 24 hours to get there by road and 24 hours to come back.
What needs to be done to prevent future outbreaks? Let's hear from Sadaya Girma.
We focus on different approaches. I think the first one is obviously to continue high quality preventive polio vaccination campaigns and responses. We have to continue investing in routine immunization. Without that, we won't be able to fully be out of the woods. We're obviously working with our partners, and especially those leading on this, and with the government on strengthening disease surveillance, because we need to be able to detect and keep an eye out for the different risks, and setting up different sites and so forth. And we also continue to work when it comes to our community engagement, sensitization, and working with the ministries of health to really strengthen existing systems.
What do you think are the health gaps, especially in Sub-Saharan Africa, where we know the problem persists?
I mean, it varies from country to country, since we're looking at such a vast continent, as you know, but we have a combination of factors. I think we can't underestimate the impact COVID-19 has had on immunization, on routine immunization, and on access to primary health care. We have a lot of contexts where we're seeing a very big impact of climate disasters, and alternating between severe droughts and then catastrophic flooding. This has an impact on not only access to services, but also communities' coping capacities and ultimately their opportunities to access to healthcare. Linked to this, a lot of gaps when it comes to where we should be when it comes to water, hygiene, and sanitation, and related to this, the spread of communicable diseases. In some contexts, very high, severe, or acute and severe malnutrition or wasting, as we call it now, which really impact the survival of children. Right now on the continent, a lot of other disease outbreaks. Cholera is a major issue. Measles continue to be a very big killer for children. And recently, and that's quite alarming because it's a sign that we have gaps in routine immunization, we're seeing large outbreaks as well of diphtheria. And finally, conflict, political instability, and related population displacement also all come into play. So we have a lot of factors that are causing all this, and this is also why for us it's such a priority. We say that looking at the data, we realized that in 2023, last year, about 80% of all the variants of the poliovirus type 2, which is the most prevalent one today, came from outbreaks that originated in two countries, in Nigeria and DRC, the Democratic Republic of Congo, where I am currently on mission. So this is our key area of focus. If we're able to get it right in these two countries, we'll be able to make a significant difference on the African continent, and we're quite confident that we'll be able to do so. We just have to really work with a sense of urgency, scale up responses with the ministries of health and the different partners, and really make sure that we don't leave any children uncovered, missed, left behind, irrespective of where they are.
That's all from us at Africa Science Focus today. If you want to find out more, head to the SciDevNet website. That's www.scidev.net. Today's show was produced by Alice Hurst, with editing by Titilope Fadari and Ogechi Ekeanyao, and reporting by Justice Baidoo. I'm Ogechi Ekeanyao. Until next time, goodbye. Africa Science Focus is produced by SciDevNet and distributed in association with your local radio station.